Do you have other things? Do you see
Oh,
anything else than
oh,
slideshow?
we're good. We have your slides here. I have no relevant financial relationships. That's what we're seeing. You should be good to go.
Okay.
Boom.
Okay. Let me see if how do you make this go the other direction?
Go down to the left, and there'll be an arrow left and right. See that?
There you go.
There you go. There we go.
All right. Okay, so this is I'm Dr. James Joseph, presenting an interesting concept and an interesting plant alkaloid called cytisine. And there's a reason why this is interesting is because it's different than nicotine. And there were a lot of people that were using nicotine for various reasons to try to alleviate certain symptoms related to maybe post-COVID fatigue. And I came across this molecule. And when I looked at the mechanisms, I realized that it's doing everything that we would want and more. And that nicotine maybe have undesirable side effects that we didn't realize, or I certainly didn't realize. So just to do the thing that we're supposed to do, there's no financial incentive here, relationship. I have nothing to disclose. Um, this material is just purely for research. You decide what you want to do with the material. I'm going to turn this off over here. And then moving forward, our objectives are to understand the pharmacological action of cytisine. Now, keep in mind, this is not cytosine, which is really a base pair in our DNA. And the other thing I got thrown off by is something called cytidine, which is a byproduct of a supplement. I thought, wow, um, we've got this other supplement that turns into cytidine, and I realized, well, that's not the same. It's cytosine. And I came across this plant alkaloid, um, it actually from overseas, actually. So we also want to analyze the mechanism of action and pharmacokinetics, evaluate cytisine's application in a real clinical settings. How does this actually apply, or how could it apply? So for starters, again, this is a naturally occurring bioactive compound, an alkaloid mainly isolated from legume plants. In recent years, various biological activities of cytisine have been explored, showing certain effects in smoking cessation. Okay, that's the primary thing. And keep in mind, this is prevalent in mid to Eastern Europe. Okay, this has actually been around for quite some time, probably over 40 years. So this isn't a new thing. It's shown certain various biological activities have been explored, showing certain effects in smoking cessation, reduced drinking behavior. Interestingly enough, there's anti-tumor, cardiovascular protection, blood sugar regulation, neuroprotection, osteoporosis prevention and treatment, and even pain of all things. And that's what got me excited about this is when you look at the mechanisms, you'll see that chronic, I'm talking about serious pain, maybe even possibly complex pain. And I hope to elucidate that. At the same time, Cytisine has advantages of high efficacy, efficiency, safety, and it's extremely inexpensive. I mean, imagine that. Maybe that's why we haven't heard about it. It has broad development prospects and is a drug of great application value. Not only in Eastern Europe has it been used in Russia. As early as the 19th century, Native Americans used cytisine as traditional medicine to induce vomiting and diarrhea. Now, it's like, well, why that? Um, and you'll find out why. It is used as a respiratory stimulant, a diuretic, insecticide in Europe. It was developed to target they may have misspelled this. It's actually nicotinic acetylcholine receptor. That's actually how they spelled it in the article. And these receptors are all over the place in our brain. These receptors are in our spine. They are in our immune system. And understanding these receptors will absolutely open up a whole arena of possibilities to help to modulate our bodies closer to balance. The purpose is homeostasis. Now, this is just a look at the different plants that this great alkaloid comes from. And these plants are all poisonous. But I think it's good to understand that medications in general, they tend to come from poisonous plants, especially when it has to do with something that modulates our neurotransmitters, which means that they can be great, but they can be bad. So something that is poisonous, I mean, how are they going to poison you? Well, they're going to induce functions in your nervous system that, either paralyze you or, cause you to, have a seizure or, something like that, kind of like a snake bite. When in reality, this is actually how the plant protects itself. And I may have heard one time you really should thank the plant for what it's providing. And I assume that the Native Americans, when they used it to induce vomiting or diarrhea, it was probably to purge something out of their system. Now, I'm going to try to keep this lecture full of pictures. In fact, I want to maybe skip ahead and I'll come back to this. This is what the molecule looks like. This is what you would call a bicyclic molecule here. And the one thing that's interesting, and I noticed, I like trying to understand, instead of trying to memorize all this stuff and that means nothing, the one thing I've noticed is that anything that ends in INE, you think of amphetamine, nicotine, you think of a stimulant. And that they always seem to have a nitrogen group in it. And then there's always this double bonded oxygen. I'm not sure. There's something about this and that plays other roles that I'm starting to notice, but this is a common theme I'm starting to see. And especially even in molecules, I noticed it in even in Amlexinox, had certain effects based on a nitrogen next to a double bonded oxygen. So I don't have any answers there, but I always look for that stuff. The other thing to realize is that cytisine acts differently than nicotine. In this particular picture, you're looking at three molecules. You're looking at cytisine, you're looking at something called CC4, And what that really is that the companies, the compounders, have been looking for different ways to make this molecule. CC4 is just two cytosine molecules bonded together. And the thing that distinguishes whether it's cytisine or CC4, and I'm not going to get into CC4 because that's something that they found some additional benefits of. I tend to like things that are closer to its natural state, but there's benefits to why they do things and combine things together. The one thing and the biggest thing is that cytisine is really a partial agonist of the receptor that nicotine is a full agonist of, that involves the pleasure centers of the brain. So when you're trying to get rid of a bad habit, I mean, if cigarettes became very dangerous, maybe there's something in the cigarettes that that either intrinsically is there or was put in there that actually caused, or perhaps people became sick. It's not nicotine really that's the bad problem. In fact, when I was looking into some of the earlier studies of nicotine, even back in 2005, patients who smoked actually had less chance of having Alzheimer's and Parkinson's disease. I mean, this is, a random scientific study, but already it shifts your mindset that, wait a minute, maybe nicotine isn't the bad guy here. And so nicotine patches were used for smoking cessation. And the one thing and the one concern, especially around COVID and post-COVID fatigue, I had patients that were concerned about using a nicotine patch because they were concerned about addiction, because they associated nicotine with a smoking addiction and smoking being bad. The reality is that nicotine can have some undesirable side effects. For example, it could cause in somebody that has blood pressure issues, it might raise their blood pressure. Perhaps somebody who has an addictive tendency, or maybe an addictive biochemistry, that you're just kind of trading one addiction for another. You're not actually helping them with their intrinsic addiction to begin with. And then there's the other aspect of this whole thing. What if there is something similar to nicotine that does all of the good parts of nicotine, but it addresses so many other problems? Now, I came up with this whole thing, or I got into it because of articles that were speculating that through computer animation of the spike protein, that a part of that spike protein molecular structure actually was identical to something called bungarotoxin. And bungarotoxin is a snake venom, and it's actually an antagonist of certain nicotinic acetylcholine receptors. And when I started looking into the different receptors, of course, like anything new, it's a little bit unfamiliar, because it's like you've got the nicotinic receptor, you have alpha 4 beta 2, or alpha 6 beta 2, and then you have like alpha 7. You have all these different combinations, And suddenly I realized, oh my goodness, I've got to learn something new, which I love to do. And I found out that bungarotoxin really targets the alpha 7 receptor. And when I looked at what alpha receptors do, well, a lot of the symptoms people were having were, you could say, were related to blockade of the alpha 7 receptor. I'm talking about memory loss, worsening of their Parkinson's symptoms, word finding problems, changes in their vision, headaches from brain inflammation. They were having increased anxiety, increased gut issues, flare-ups of their autoimmune diseases, worsening of their pain. And the list just went on and on and on. And guess what? Alpha 7 nicotinic acetylcholine receptors. Can you believe that? They're even in the dorsal root of the spinal cord. So if you're dealing with somebody with complex pain syndrome, which is really, it's really the nervous system is created too many connections and anticipating danger, I guess you could say. And then the, pain is much more magnified than the actual stimulus that a person experiences. So I figured, well, maybe we're onto something, because I've certainly had a lot of patients with complex pain that were difficult to treat, especially when you're trying to treat them the natural way and not cover things up with more medications that have more issues. Okay, so I figured, why don't we just pretend like we're learning all over, and let's just learn some basic things so that we're not imagining. We got a nice picture here to remind us at least the basics of nicotinic receptors. And these ones are involving dopamine. The other thing I've noticed with patients is that they are reporting that they have not only lower mood, they are having decreased, I don't know, like I had a patient, he said, I don't know how to describe it. It just feels like I have no dopamine. They're having trouble, they're feeling energetic, they're having trouble with their libido, they're having trouble thinking. I mean, here's her frontal cortex right here. And word finding here, the hippocampus this is where our memories are. This is the, I knew I was gonna forget what the abbreviation was as soon as I as soon as I did the lecture, but it'll come back to me. We'll come back to that. What this is, the nucleus accumbens is actually the pleasure center period. That's the pleasure center. And if you look at the root word here, if you ever want to try to remember it, I like to look up the old Latin and Greek derivations, or the root word. And accumbens actually is to recline or to lay down. So either a person is, the way I see it, either a person is laying down and they're feeling really, really good, or they're laying down because no dopamine. Striatum actually means stripes. So these are the stripes. And you must realize that the ganglia is actually here. Substantia refers to many things, and when you look it up, think of substantial or substance. this is something of substance or even of wealth. That's why this is really important. And this would be really, this is the ventral thalamic. Well, I should probably take some cytisine and I would remember. Uh, but this stands for really a hard core. Okay. So if you just got that down, you'll know what's going on. And just know that the hippocampus in general also uses glutamate as its primary way of functioning. Glutamate is excitatory in its own way. The pleasure is here. And then there's other aspects of other mini pleasure centers that maybe they're more connected to the olfactory bulb or that connection to the olfactory bulb. And that would relate to pleasures based on smells. And there's other areas that maybe where the receptors are such where they would be more receptive to one addiction versus another addiction. And that's where the strategies to help with addictions actually come into play. Okay, so my assistant, who's a patient of mine, I treat him for muscular dystrophy. And he, we've become good friends. So I help him with learning this stuff and finding answers, trying to find answers for him. And he loves to do these slides. He told me, let's put, instead of typing these out, why don't we just put your authentic notes down? So I said, okay, let's give it a try. So these are just these are my thoughts here. This is not coming directly from the article. This is me trying to translate what I'm reading, because sometimes it might be because of translation of the articles, if they're going from a different language, that something isn't quite lining up or making sense in the way that they describe things. And so this is really how I describe it. So in general, without learning 20 different combinations of alphas and beta, this and that, the main ones really to understand are these. And the most abundant one here is in the brain is the alpha 4 beta 2 receptor. And that's where nicotine has high affinity. It's a full agonist. And so you get all of the good things as far as concentration and pleasure when somebody takes it. But then I remember when I was experimenting with nicotine, I also got the nausea and those kind of side effects. And for some people, their blood pressure rose up. And when we're trying to treat somebody medically, we have to be mindful of that, if they have a history of blood pressure, or in general, if their blood pressure is rising and they have, chronic diseases, which is what we specialize in, we got to think. And that's what Dr. Burgess said last week. It was quite entertaining. We just need to think about it. So that's why I wanted to make this simple and straightforward, because it doesn't have to be so complicated. We just have to think about it. Now, cytisine, takes time to pronounce it. Cytisine is high affinity for alpha beta 2, but it's a partial agonist. So yeah, I mean, you could probably say, if somebody was smoking, they're probably going to want to take the cytisine with it for a little while, because at least it will compete with the nicotine. Or if you're transferring from a nicotine patch, somebody started on that, you might want to continue it, maybe, the low dose, or cut it in half and add the cytisine for a week or two. These are just my ideas here. Because if you may experience some withdrawal symptoms from your concentration potentially could go down. But I'm gonna take that back. That may not be the case. And the reality is that there's this other receptor. Okay, and both of these receptors are in the nucleus accumbens, the pleasure center. The other receptor, nicotine has less affinity to. It could still activate it, but cytisine has the same affinity as the alpha 4 beta 2, but it's almost a full agonist. Okay, this is where I got confused at first. So everything is relative. So you're really just stepping down a little bit. And so you can go straight from nicotine to cytisine. So take away what I said before. I apologize. You don't necessarily have to combine the two. You could, but you don't necessarily have to, because it compensates with the other receptor. Now alpha 7 isn't in that pleasure center, but it's in a lot of very interesting places. And the difference between the reason why nicotine it's not being used for chronic severe pain, or say a neuropathy. Okay, last week we talked about, Shell was generous enough to tell his story of trigeminal neuralgia, a severe pain with swallowing, with chewing, to the point where it was becoming difficult to talk. He had some results with actually using amlexinox, which does address the certain inflammatory pathways and has certain mechanisms that relate to neuropathic pain, but not quite as specific as this nicotinic route. And we tried a lot of things, and eventually, as I got familiarized and semi-fluent with nicotinic receptors, I said, let's try nicotine. While I had to order cytisine from Poland through Amazon. And I like to try things first myself. I don't want to just, experiment, say, here, you try it. I'll be the guinea pig. I'll take it, make sure it's legit, make sure I'm not having any weird side effects. And the most wonderful thing happened. He actually put the cytisine up under his tongue. It's not a sublingual. I've put it up underneath my tongue. It doesn't taste bad at all. Actually, it tastes quite nice. And his trigeminal neuralgia actually stopped. Now that blew my mind. I was like, I hope he's just not trying to make me feel good, and encourage me. But it actually went away. And just to test if it wasn't just a placebo effect, he just stopped. He just waited till it came back, and then he tried it again the next day. Cytisine, by the way, is something that you take 4 times a day. According to the stop smoking protocol, but it's because it has a half-life of about 4 hours. Well, his trigeminal neuralgia continued to stop, and it really never came back. Now we're speculating now, if there's breakthrough pain, can you add something like lithium? I'm talking about lithium orotate. And so, I'd like to say that we found the magic bullet. It's gone, and we don't have to worry about it. And I'm pretty sure it's mostly gone, but it may be that lithium, if by with lithium orotate, I think it's great for sleep. I think that it's actually good for brain regeneration and reducing brain inflammation, and it's good for Alzheimer's, and it's also good for Parkinson's and memory and brain regeneration. That will be a subject of the next lecture. And also good for avoiding neuroexcitability, which is my concern, is as the electromagnetic frequency, if it's actually getting stronger, which is something that I think it is, that we need to be able to control the neuroexcitability of our brains. Because what happens when our brains become neuroexcited is it's all about those calcium channels. You know, we get too much calcium in our cells. That gets uptaken by the mitochondria, and then that excites the mitochondria and produces more energy. And what I've kind of come to realize is not only does too much excitability, too much energy production can lead to inflammation and headaches, and if somebody has tinnitus, it can exacerbate tinnitus, anxiety, insomnia. All right. But it's just like a car. You can only run it so hard for so long. And the digestive tract, the endoplasmic reticulum of the cell, which is really the protein production line, is where the proteins are being put together. Just like in that picture, I'll actually come back to it. I don't mean to jump around, but I think it's important to get this. This production line is very important, because if this can't keep up with the amount of energy that the mitochondria is producing, it's like creating more demand for more production. It can get backed up, and when it gets backed up, things get jammed. And the way I see it is the proteins that are being produced, in this case, it's receptors. If they are not getting a signal, if that engine doesn't slow down and give them a break and which will flip on autophagy, okay, you're not going to be able to get rid of. It's like a manufacturing plant. If the conveyor belt is going too fast, the parts might not be put together correctly in time, and then you start pushing out proteins that are incomplete. And guess what? That's where you start to get, say, alpha-synuclein or bad proteins that lead to bad things with Alzheimer's and Parkinson's, or just misfolded proteins. And I guess what, and then, and in simplest terms, then what do misfolded proteins do? Because everything has a function. Well, they trigger oxidative stress, and then the car engine heats up the mitochondria, and it blows up, or it goes through the process of apoptosis through very specific mechanisms. I hope that created clarity.
You know,
Now,
doc, Dr.
okay.
Joseph, it
Yes.
it did, but Dr. Artist and Dr. Ely, they recommend anywhere from 3 to 7 milligrams of a nicotine patch to take on biowarfare, to take on COVID, to take on whatever you want to call what's going on. And you can get a 7 milligram patch, cut it up into 3, and supposedly it helps with all the above. So I think you're on to something
And
that,
that's, but
go ahead.
yeah, you're exactly right. I'm on to something. No, and I'm glad that you brought that up because that's a big segue. Because you're right. Because if something is blocking alpha 7, now alpha 7 is in the vagus nerve. Okay, I mean it's in your memory. It's in the hippocampus. That's that's the that's the big issue. It's in the inner ear. And it's also on the innate immune system and the adaptive immune system. And
Okay, can I add something here which will help to reinforce everything you say? Now, cis cytosine is way better than nicotine because they are specific for 7 alpha receptors. Nicotine works on all those receptors, but you need something that's specific for this receptor. And when you see the mechanism of central pain, which I have a very big lecture on that, showing animations about the whole process of the initiation or the progress and of the central pain, which is it's due to changing in the neuroplasticity of the brain, and it's progressive neuroplastic changes that's happening in the pain pathways in the brain, where the overactivation of the pain pathway, which is the sending pain pathways, they lead to formation of more synapses and decreasing the threshold, and then you have this allodynia and hypergesia. I think that's the problem with neuralgia and complex regional pain syndrome, where you have hypertrophy. I like to say neuroplasticity changes that leads to many synapses and connection form in the ascending neuropathic pathways, or the neuroceptive pathways that carry the pain signals. So your nerves that carry the pain signals all the way to the what's the name of the center in the brain where the pain is? I forgot the name of it. But there's a center there,
basal ganglia or
not the
amygdala.
basal ganglia, the other one in the center. It's part of the basal ganglia, but there's a center, and it's a block out. But yeah, there is. What is
No,
the name
that's
of it?
um gosh,
Doesn't it
no.
There's
start
a
with a P? Doesn't it start with a P?
yes, it's in the center of the brain. But regardless, there's a where we feel the pain, and I just forgot the name. It's block out, but that pathway of pain, it's mediated by glutaminergic neurons. So you have too much of glutamine is being released, and this glutamate, it's inducing inflammation and neurogliosis and oxidative stress. And oxidative stress, it's actually potentiate more of connections and synapses of the nociceptive central pains, and you get more connections and you lower the threshold, and that leads to they become very hypersensitive, those neurons in the brain, and to the point you have allodynia and hypergesia
Is
and
is it the pons? Is it the pons?
not the pons, no. It's the center of the pain in the brain. I will come up with the name of it when I finish up my train of thoughts. But anyway, so
Halasa, it says amygdala.
amygdala. Thank you.
Yeah,
Thank
the
you. See the
central
IDP?
amygdala.
Amygdala. Thank you. Amygdala. Yes, amygdala. So amygdala itself, with those patients with neuralgia and complex regional pain syndrome, they are bigger in size, and the reason because they develop more synapses. So the oxidative stress level that is generated by the glutamate, it's causing progressive neuroplastic changes, more synapses, and more this area of the pain neurons become bigger because of more synapses and more growth and more dendritics and more connections and lowering the threshold. So it become very sensitive. Even touch can trigger pain because they end up crossing the line and connect to the touch pathways. And that's where patients is becoming way sensitive. They cannot chew gum, like Shell say. He said, I cannot chew the gum. If you touch him, he feels pain. He cannot smile, right? And so you have this central pain pathway are all connected. The inflammation, oxidative, it's caused, and that same inflammation, same oxidative stress level, it's causing the progressive neuroplastic changes, which is more connection synapses and more inflammation there, more gliosis. It's causing atrophy and regressive neuroplastic changes in descending analgesic pathway, which puts the brake on the pain signals, right? And so what does the nicotine does? See, this is the beauty about this nicotine receptor. They are in the neurons of the pain fibers, and also they are in the neuroglia. And what it does, it expresses the glutamate reuptake transporters. So think about it. You are bringing all those glutamate back to the neurons and to the glia cells. So you are decreasing the glutamate level at this nociceptive pathways, the central ones. And when you decrease the glutamate, you decrease the excitations of this neuron sets. And when you decrease the glutamate, you decrease the opening up of NMDA receptor, you decrease the opening up of calcium channel, you decrease the releasing of oxidative stress in the free radicals from mitochondria, you're decreasing the inflammation, and you're normalizing the neuroplasticity back. So all this dendritic that's being connected with axons in the body, they all shrink and they decrease and normalize. So you would end up returning back to the threshold level because all those extra dendritic connections are all being atrophy and decrease. And then you have normal connection, normal neuroplasticity, and that puts the whole central pain down. Now, we can do that with gabapentin, which blocks the NMDA receptor. But here's the thing, that's not enough. I think expressing the glutamate transporters, it's even way better and more permanent because it's genetic expression inside, and you are clearing up the glutamate instead of blocking the NMDA receptor and preventing glutamate from combining. This gives you a short-term effect because once the block goes away, then the glutamate will start combining, have the pain again, and you didn't do much. This nicotine receptor, it signals the expression of glutamate transporters, and it helps to get rid from all this glutamate. And if you do that, then you decrease the excitation of those nociceptive neurons, and if you do that, you help to decrease the central pain. And if you do that, also you decrease the signals that and restore the neuroplasticity of the descending analgesic pathway. And then you have the enkephalin is increased and dopamine is increased, and I think this is a very good medication that is alternative to GABA to manage oxidative stress, to manage central pain, to manage allodynia and hypergesia. It is equivalent to GABA, but it's better than GABA because it works in a different way. In the state of blocking an NMDA receptor and blocking the glutamate effect, you are increasing the expression of the glutamate reuptake, which will help to clear the glutamates, which eventually decrease its activities. And this will normalize the neuroplasticity of the nociceptive pathways. And that would, the patient will get rid from, definitely will feel better. So this drug.
This is
Dr. Halasa, what you are saying.
Hold on one second. I just wanted to give our guests a chance for to regain their dopamine in their brain from learning this. This is beautiful, and this is why I work with Dr. Halasa, is because there's value in true, pure logic of understanding this stuff. Because he's right. Because cytisine also doesn't have any of the sedation effects. People who take gabapentin, they're miserable. The ones I talk to, Lyrica, they're sedating. It's only addressing one thing, and you'll actually see it later in the presentation. I'll show you exactly what's happening. You'll understand it, and you'll never forget it. It's simple, but it explains why this is in a completely different arena. It makes gabapentin look ridiculous, actually. But go ahead, Dr. Patel.
Yeah, I was just wondering, so what Dr. Halasa was telling about the glutamate, so it in the comparison to the cytisine, so what increases the neuroplasticity? Because if you're talking about neuroplasticity and you're talking about the the pain relief or the there are many effects of cytosine that we can use in our COVID patients, and we can use in our so many patients, those who have unexplained pain, and whether does it work for the the pain coming from the ligaments and pain coming from I just want to have the understanding, because a lot of nociceptors are coming from the skin, and fiber C unmyelinated fibers and fiber A, delta unmyelinated fiber. So there is a peripheral pain mechanisms, and this one is for the central pain mechanisms. And is there any connection between that we can also use it for the peripheral pain? Because some of the gabapentin is used for the peripheral pain mechanisms, where there may be a central pain, and it's considered having the manifestation in the periphery and manifesting as a peripheral pain. So I think when there is too many information floating at the same time, it will be very hard for the listeners to really dissect and understand that under what conditions we can use these or we can use that. So I would appreciate that if you can take little time and explain that.
Well, I think this is very complex topic, but if you remember, I have an animation of mechanism of central pain and how a continue activation of the central nociceptive pain pathways leads to progressive neuroplastic changes. And that progressive neuroplastic changes means that too much of glutamate's activities open up calcium channel, leads to oxidative stress, and oxidative stress, it's causing growth of dendritics and connections and more connections in that pathway, and lowering the thresholds of the central pain pathways, and they become bigger, and amygdala gets a little bit hyper and bigger in size because they're developing more dendritics and more connections, and then that has to do with excessive of glutamate release, oxidative stress, and oxidative stress, it's inducing growth, not atrophy. It actually, the oxidative stress, the same oxidative stress that's causing growth of those dendritic cells and progressive neoplastic changes and lowering the threshold, it's the same oxidative stress and then neurogliosis and inflammation that leads to atrophy of the descending analgesic pathway. And why the reason? Because it's genetic. The neurons of glutamate respond different from the the descending analgesic pathway, which is mediated by enkephalins.
I tell you what, let's move forward. We can come back and fill in.
Yeah. I think this topic will end up. Yeah, let me just make my next statement here.
Okay.
This topic, I'm gonna have a presentation again with animation, and then I will bring the mechanism of how, so you can see it with animation. So Dr. Patel, it's not gonna be easy to visualize it now, but I think with animation you can. But what Dr. Joseph is bringing, he's bringing a very important agent that replaced the GABA in managing specifically the central pain. And that's something we need to learn from today.
Perfect. Thank you very much, by the way. That's excellent. And I mean, beyond excellent. So, okay. And then you see here, alpha-7, the difference is because cytisine is a full agonist, not as much affinity as the 6.2 and the 4.2, but way more than nicotine. That's the difference that makes the difference. I had to toil through this. Everything's relative, and I finally made sense of it, at least within the way that I see it. So, okay, pharmacology of cytisine, reduced addiction. We know that. This is what I talked about. They've made a CC4, or when they're testing this stuff, they're trying to look for different combinations to see if they what they do. and found that had its, you know, its value. This is the mechanism here. This is the pathway. This shows the cytisine up here interacting with the same two receptors, CC4 and this one. They both don't even worry about CC4. Just get the main gist of it. They are partially agonists of the acetylcholine receptor, but they reduce the addiction, that should have said that, to nicotine, because it's lowering alpha 4, less of that, but more of the alpha 6B2, but not quite as strong. It's not a quite full agonist. That's the difference that makes the difference there. So you don't go through withdrawal and start exhibiting those signs. Now, some of these other mechanisms, I'll keep them short and sweet because I think it's more important to get the point. This same process is happening to reduce drinking behavior, and via the same mechanism. This ADE has more to do with this addictive behavior pattern for wanting another drink. And that this FOSB is just something that modulates the DNA. So there's a genetic sort of alteration as well. So you're still producing dopamine with cytisine, but you don't have the negative behaviors. Okay, so the same thing can be said for somebody with a sugar addiction, and it's similar. It's again, this is the lay down, the pleasure center, and that's all you have to remember. I mean, really, there's only one. Oh, sorry, didn't mean to speed up ahead here. And it's a similar thing. It's because sugar increases the alpha 4 beta 2 receptor. It decreases the and this is receptor. And now this is another thing to understand, is that nicotine and cytisine, they both upregulate the receptors. And that's a beautiful thing. If you think about if say a snake venom is blocking, antagonizing a receptor like alpha 7 that you need, well, if you're not only stimulating the alpha 7 like the other ones, but you're also creating new receptors. Okay, so it's not like there's a limited amount of receptors. In this situation, you can see that there's a decrease in receptors because the sugar does not, it's similar. It doesn't touch, it's really only activating the alpha 4 beta 2. Then you add cytisine. My goodness. I'm trying to point with the pointer, but it keeps going to the next thing. So I'm just going to explain it. Here's what it is. It's basic. It's simple. You increase the dopamine because you now, as a partial agonist, you're not going to produce as many of those alpha 4 beta 2 receptors. But at the same time, you upregulate the 6 beta 2 receptors. So and guess what? In this particular situation, this is where it gets even more, you have to make a fine distinction. It's the alpha 4 beta 2 that's really responsible for the actual sugar craving. Well, scratch that. Scratch that. Just know that you're getting the dopamine without the sugar. You won't crave the sugar because you're getting the dopamine from the other receptor. It's upregulating the other receptor, and the receptor that was being stimulated by the sugar is now downregulated. Makes sense. Simple. There are some cases, like they did a study where cocaine actually activated the 6-2 receptor but not the 4-2 receptor. So there's situations like that where certain drugs have more affinity for certain receptors. You just have to know which one then to, just stimulate the other so that you get the dopamine release without the need for the thing, if it's a street drug and, used in a destructive way. Okay, so again, something's blocking my screen. I'm trying to remember. This is the pathway, and we don't have to go into it so much. This part has to do with people, diabetics who are hypoglycemic all the time, and they may lose their ability to stimulate their adrenals and to produce glucagon, which gets released. It's like the from the pancreas. It's like the opposite of insulin, and it leads to restoring via the same mechanisms. It restores the liver's ability to produce the sugar again, so that they don't have the hypoglycemic episodes. So it just seems like everything lines up with this. So okay, so epileptics. Now I'm putting this here, and I'm going to keep it simple. And I know that this is the Tuesday call, not the Monday call where we go on for 3 hours and geek out over every scientific topic imaginable. So I'm going to simplify this whole thing because there's something here in general that this threw me off when I was toiling. And I believe this is what Dr. Halassa was talking about. This was based on a study. This is a temporal lobe seizure, and was causing that hyperactivity of the glutamate. Remember that's that hyperexcitability of the neuron. That's where the problem is. And again, it's like, well, should we control the seizure disorder with a manipulated GABA, which is gabapentin, or is there a better mechanism? So here's my notes. This is how we understand it. Okay, let's go to basics. Let's think about it. In seizure disorder, the balance between excitation and inhibition is disrupted. There's two things, they're opposites. For every one thing, there's an opposite. Glutamate, excitatory. GABA, inhibitory. Now, this is where the alpha-7 has its place. Alpha-7 stimulates glutamate. Oh, but wait a minute. That's exciting it, right? No. Well, by itself, yeah. But guess what? There's two other things working in the other direction, because alpha-7 also stimulates the GABA neurons. And alpha-7 modulates the neuroglia. And guess what? Alpha-7 via that, so it's 2 against 1. There's 2 against 1. And keep in mind, I didn't say it was a alpha-7 like full-on powerful, like pushing an electric gun or anything. It's not. It's just stronger than nicotine. It's strong enough. Probably it's not affecting a nerve that's already in an excited state, but it's slowing down. But it is activating GABA neurons, and it's enough to modulate the neuroglia, and that process enhances the glutamate clearance, just like Dr. Halassa said, at the synaptic cleft. And I have a nice little picture here to show that. And this is where where the seizure is happening. Okay, this is the glial cell, and that's being activated. And also at the same time, this is even without GABA. GABA is being activated, which is helping to reduce the glutamate in general. But at the same time, the glial cell, via this alpha-7 receptor, is sucking the glutamate into it's taking all the glutamate away. So it's breaking up the connection there. Brilliant. And so in that study, it showed that threshold that the seizure disorder was controlled over long periods of time, because every time it would get started, if there was a breakthrough seizure, it was probably mild, because the mechanisms are all that mechanism is all working simultaneously at the same time to reuptake, and that's really what it's doing. It's reuptaking the glutamate away from the excited neurons. Parkinson's, characterized by progressive degeneration. Now, I'm not gonna go too far into it, because I think it's important, again, to get the gist of it. And we only have so much dopamine and glutamate in our brains to, get all this stuff down. But just know for now that, remember I talked about the endoplasmic reticulum getting backed up? Well, that's actually called ER stress. That's endoplasmic reticulum stress. The factory gets backed up. It doesn't get there's intracellular calcium is not being regulated. And that's another reason why we can come back to Clotho. See, Clotho fits into this whole model, because Clotho is the master regulator of intracellular calcium. Okay, it actually helps to the receptors to actually function, and to function efficiently, to not allow too much calcium into the cell, and regulate it, so it doesn't get to the point where the mitochondria is overexcited all the time, to the point where the neuron dies. And because the ER stress that never gets a chance to get rid of the bad stuff. That's what it does. It would take those misfolded proteins and send it to the trash bucket, which is autophagy. But instead, they get pushed out into the cytoplasm in the form of alpha-synuclein, which actually the synucleins actually have a role. The problem if you get too much is that then they start to turn into alpha-synuclein plaques. And what I didn't say, and I wish I would have mentioned it, I'm just going to jump back. We're actually almost done with the lecture, because just knowing this makes perfect. The other thing, the advantage of cytisine is that nicotine loads up the receptors into the production line. It stimulates the production line of new receptors. But what it doesn't do is what they call chaperone the receptors after they're built to the wall. And I'm not sure exactly why, and I don't think we have to get into it. The nicotine is, in a way, is contributing to the traffic jam of the factory. It doesn't have the mechanisms via cytisine. It helps to pull those receptors out and takes the stress away from the endoplasmic reticulum. So it may be working on Parkinson's by helping to reduce the endoplasmic reticulum stress, because it's helping pull the stuff out and release the blockage that's happening. You don't have to worry about this. This MPTP was a drug that blocks the mitochondria and causes the traffic jam. Okay, and that's what led people who took the wrong street drugs, they developed Parkinson's. That's all we need to know for right now. We won't get into all this other stuff. That's just I think knowing that alone, reducing the endoplasmic reticulum stress, that's a way, that's something to focus on and know why you're doing what you're doing. Anti-cancer effects. I'm not going to go too deep into it. My understanding is that in that context, it has more to do, again, it has to do with the alpha-7 receptors, but it's just enough stimulation. Here's the thing. It's like it's enough stimulation with struggling cells to help those cells. And when you're dealing with a cancer cell, you're, okay, alpha-7 receptors are actually very, they're actually very permeable to calcium. Okay, so I think what happens is in the Parkinson's cells, the substantia nigra, those neurons, I think it's giving it like more like a burst to push things along. Okay, just to push it along. Because those other nicotinic receptors do not leak calcium into the cell. So it may be a little oxidative burst on top of oxidative stress to just sort of jumpstart it and move that and get it to push that stuff through. Like almost like if somebody's choking on a piece of meat, and you just give it a little thrust and then you spit it out. That's how I see it. In the context of cancer, it's just enough calcium to cause all the processes that would cause the mitochondria to blow up and undergo apoptosis because it has the mechanisms are set for a certain amount of much more oxidative stress than a regular cell can handle. And if you just nudge it even further, then it kaboom. So that's how to make sense of all of this complicated stuff, at least from my perspective. You got your alpha-7 here. You have a cancer cell that's adapted itself to it's like a car that's in first gear because it's the Warburg effect. It cuts off. It's only operating off of glycolysis. It's not operating off of the citric acid cycle or the electron transport chain. And it's got so much oxidative stress. And then all of a sudden you come around with just enough stimulation of calcium. And it's like it's at the edge of blowing up. You just nudged it over the edge and kaboom. I guess it'd be like, something that's very volatile and it blows up very easily. If it's done in just the right way. Analgesia, we beat that subject up. Just know that the effects of, as they were testing things, this is how to think of the analgesic effect of nicotine versus you know what? I've never tried. I read it, but I never pronounced it. So epibadidine is 100 times that of nicotine. Now, this might be a language barrier here, but epibadidine has a high affinity with cytisine. So if it's 120 times that of nicotine, and it sounds like it's comparable, cytisine is closer in the efficacy to, that shows you that they're in a different league, these two. And cytisine doesn't have any sedating effects. It has all of the, actually, you're reducing pain while you're you're getting dopamine release in your pleasure centers. I mean, think about that, and that has effects, has positive effects on pain. So you're not depressed. And just so to give you the picture here of where the epibetadine comes from, it actually comes from a frog. Cute little thing, kind of looks like a hot pepper. And just to show you that it's there's a common theme, that's what it uses to protect itself. It produces protect itself, just like plants. And ironically, if you look at the molecules, the one on the left, and you look at the one on the right, this one comes from the frog or the red hot chili pepper. And this is actually a chlorine. You have a chlorine here instead of an oxygen. You still have this nitrogen here. And you see, look, there's plenty of things in nature. We can utilize that, whether they come from plants, whether they come from animals. We all have these things to protect ourselves. If they're utilized the right way at the right dose, you can have all of the positive effects essentially, and without the negative effects. And like anything, too much of cytisine can be an issue. I didn't bother to talk about it, but yeah, if you took too much, you're going to have nausea and vomiting and undesirable effects. But that's like anything else. That's why the dose has to be made right. So it's received much attention for its advantages of high efficiency, safety, low cost, multi-efficacy, is a natural compound with great promise and great value. I would say it's received much attention, not in the United States. Of course not. I mean, come on. I mean, that's just the way that seems to be the pattern I see. Its molecular structure has some similarity to that of nicotine and has similar pharmacological effects. Just so much better, in my opinion. And that's where the Chantix actually came from. They changed it a little bit. It's got all the same actions are the same. And it may be more, when I'm trying to figure out how do I treat patients and get the stuff, if I got to order it from Amazon in Poland, you can get it. Okay. You can get it through certain, you can find it online. But if you want it compounded, the main thing here's what it is. This is the big conclusion. What I realized is that when you take cytisine by mouth, you're only getting about 30% penetration of the blood-brain barrier. Okay. So the idea is, if there's a way to compound it such that maybe we can deliver it safely through intranasal, or we can have like a actual sublingual, like Shell did it, the actual pill, that's nice. But if it could be put into a more absorbable form under the tongue, then what's possible? Okay. Then what's possible? But I really think through the nose is really where it's at, because it's about and think about this. There's another thing to think about. Maybe there's some value in it under the tongue too, because there's alpha-7 receptors in those autonomic nerves in the tongue and the nasal passage. And my question is, does it have would that help somebody with loss of taste or smell, or altered smell and taste? You see how it just keeps getting better. That's all I can say about that. It keeps getting better. It has a short half-life, so that but it does get eliminated quickly. So it's something to use. It probably has to be used multiple times a day or as needed. But if we can have it made intranasally, my idea is to have cytisine made intranasally, and then if the pharmacies are concerned that they're using products from overseas, or it's not going to fit with the very, very controlled country that I don't even know if it consider this well, I'm not going to say anything. So we do have access to this, and what matters to me is what is results. And that's my presentation. Thank you. Any questions?
Are you there?
Yeah, is anybody?
Okay, so let me just emphasize on everything you said. I think we understand that this nicotine receptor agonist, which is partially agonist, there's another version of it. It's called varenicline, which is synthetic form of cytisine, and varenicline is FDA approved. Cytisine is not. Varenicline, you can compound it from the compounding pharmacy in the United States, and we can form intranasal formulation for it. But cytisine, its alkaloid is more natural. The big pharma, they tweak it and turn it into varenicline so they can make money out of it. But what they learned mechanism of action is that it increases the synthesis of GABA, and that's a good thing you need for pain and for anti-epileptic actions, and also for it helps in sedation, but not to the point of losing it. But so that's what, and also it increases the release of dopamine, so it can be used for Parkinson. And I think that explains why people that are smoking, they say nicotine helps in managing smoking, and possible because of its effect in releasing dopamine. So it does increase the dopamine release, but it's not as much as nicotine does too much of dopamine, so you end up with addiction. This one, it's 50% of nicotine does, so you can discontinue from nicotine with varenicline or with cytisine. It's either both way. And also it increases the expression of the glutamate reuptake receptor, which is something that we need because the glutamate is the inflammatory and neurotransmitters that leads to the progressive neuroplastic changes in the amygdala and all the pain nociceptive, the central ones. And we need to normalize that by giving this varenicline or cytisine. So everything, it's in favor of balancing the brain activities and normalizing it, optimizing it. I do recommend, as Dr. Yusuf said, and I concur, that if we can develop intranasal formula for it and do it in a way that maybe based on cyclodextrin as a nanoparticle, then we can come up with better delivery into the brain. Something we can work with the compounding pharmacy for that. But I think if there's anybody has questions, Dr. Joseph James, you're very good. I mean, excellent. I mean, it's like you're the one who's now you're bringing things to the table, exotic things that all the doctors here. I mean, those are very unmet medical needs. Finding other solution than what we have for central pain. It's a big thing, and then hands-on experience it with your patient with neuralgia. and presenting your case here, and all the other treatment that's currently being done did not work, and this one worked, which is the missing link. You're filling up the gap. I mean, this is like phenomena here.
Thank you. Yeah, and then if and what if we did have the nasal spray when Shell was using it? Would that have been enough alone? Although I do recommend now lithium, and the reason is because whether you feel it or not, or whether you don't want to admit it, you are being like electrocuted in this environment. You may not feel it, or you don't want to admit it, or you're pretending not to feel it. Sorry, that's just how I am. I just, things just come out of my mouth. You're affected. What things have slowed down. People are forgetful. We're like America Homo the zombies. Whether you want to, and maybe you don't want to think about it because it makes you depressed, but it's true. So we have to come up with more exotic ways, and we have to think. And I like to figure these things out. And that's just my passion is getting to the truth. But we need better strategies for a more intense environment. And I think if we can control what the hyperexcitability of our nervous system and the calcium influx, we can survive. And my biggest goal has always been to feel normal.
So what dose of lithium are you talking about?
Well, I started with good question. Lithium orotate, 5 milligrams. I actually went up to 10 milligrams. It's been a couple of weeks. I had a nice, calm night. Today I felt very smooth. My issues revolve around, it's not just tinnitus. It's hearing the cell phone signals. I mean, it's like hearing a high pitched noise, and it's very intense, and it causes me to have headaches, and I think it's very dangerous. I think it's dangerous to pretend that that's not happening. For me, it's real because I have it. Not everybody has it, and that's okay. I have I found that certain people have that, but then other people have other issues. I have a patient whose issue is nystagmus and vertigo. They don't have any tinnitus, but there's a common theme. It's what part of the brain is being hyperexcitable. And if the neurons are hyperexcitable too long, guess what? You're not going to produce the dopamine because the dendrites, like Dr. Halasa said, are going to shrink. Remember, they're coming from the pleasure center. Dopamine is coming from the ventral tegmental part. And tegmental just means integrity. It's very strong and protected shell. But those neurons those striatal stripe-like nerves that are going to the nucleus accumbens, they, according to one article, they shrink, and the dendritic connections shrink. And guess what happens when that shrinks? You're not getting the stimulation you're unable to produce enough of, and because of the oxidative stress too, you're not producing enough dopamine to feel pleasure, or those neurons go to the frontal cortex, and those are shrinking, and then dendritic connections are shrinking, and so you can't think straight, and some people more than others. I make myself think straight, but that's why I test these things out, and I feel like I'm thinking pretty good. But if you don't, I guarantee you it's not going to be long before your brain, for you really see what I'm talking about. Maybe I'm a
Did you have tinnitus too? Did you have ringing in your ears?
Did I bring? Oh, with what?
With the EMF.
Oh, yeah, 100%. And the reason why I was looking for a stronger version of the cytisine was because, well, first of all, my concern is if It's a GABA agonist, but it's also a dopamine agonist to a degree that it's like oxytocin. It can go both ways. It could help your sleep. The first night I took it, I slept like a baby. And then one night I took it and I couldn't fall asleep till it was impossible to sleep. That's why the lithium orotate was added to the table. And now we're looking into elemental microdosing of elemental lithium. And the reason is the lithium modulates the toll-like receptors of the cells, and which reduces the pathway leading to NF-kappa B, leading to inflammation. Okay, so I was also having issues with waking up with headaches. If you don't get these things under control, look, bad things happen. Strokes, Parkinson's, Alzheimer's, you're going to start building up plaques, tumors.
Yeah.
All right, so
Yeah.
at least we're prepared. We're forward thinking, so that we can not only protect ourselves, but we don't want to get blindsided with cancer or realize that we're not functioning. And yeah, go ahead.
We do use lithium orotate, and just like you said, 5 milligram, maybe sometime 1 time a day, sometime 2 times a day, in our chemically sensitive patients who are EMF sensitive. And we thought that it has an effect on the cell membrane and cell membrane frequency. So maybe there are just more interconnections. And particularly, I had some lithium orotate which just expired in my office. So I said, okay, I will take it myself. And because this expiration date is something that you have to remove from your office. So took it, and I mean, I agree with you that there's a different kind of calmness that you experience in your brain. And then when I was doing the the whole body laser light therapy, it had a tremendous effect on my mental creativity. Was just going through the roof, kind of solving the problem, writing whatever I needed to write. So I agree with what you are saying, that it has a tremendous effect, even very low dose. So we are not using lithium carbonate at 120 milligram, but we are using lithium orotate 5 milligram, and it has a good stability.
Yeah, and that's a whole nother lecture, because that actually, when that for sometimes you get a tip from other physicians that they say that one thing and everything changes your paradigm. And there's a physician, I had met him one time in the compounding pharmacy down here in Florida. And it's an old pharmacy with lot of wisdom there. And he said his number one treatment for Alzheimer's, and he said lithium. I was like, lithium? And I realized I was stuck in the paradigm of lithium carbonate, manic depressives and sedation. And even if you look at the element, it's similar to similar to magnesium. So it works with it and has that same similar calming effect, but it's the mechanism actually has more to do with blocking the master regulator of NF-kappa B, which leads to inflammation. So it's really the neuroinflammation and oxidative stress that is we're doing. I see magnesium as sort of balancing out calcium. So the way that I visualize things is that we try to come at things from different angles appropriately and let them collectively work together. And then of course, then clotho is the master regulator of these receptors. It's the cofactors that they all need to move quickly and smoothly, and sodium channels get produced and get up to the cell wall, and the calcium can get in and out the way it should, and not just get stagnant and stuck, because that's what levels go down. And then you end up in a hyperexcitable state, and chronic inflammation and plaques, and then a spiky protein comes around, and that really in the form of snake venom that blocks all the receptors, nicotinic receptors that exacerbate the problem even more. And then you can't figure out why you're chronically brain fogged. Really, you're turning demented, in my opinion, for the most part. It's okay to say, if I don't get this handled, I'm going to be demented in the next year or two. I mean, just throwing that out there. You could be 40 years old, 30, you could be 30 something, and it's okay to say, to think and say, I'm becoming demented. I'm not just brain fogged. I'm exhibiting all of the signs of early dementia.
Can I ask you one more question about cytosine? That how often do you see that blood pressure goes up, and at what dose? Because it's important that patient, if he's on antihypertensive medicine, how do we approach that?
Yeah, so I didn't get a chance. I realized that the lecture was going to be too long if I got into every system. I wanted to get into cardiovascular, but I wanted to get into Parkinson's even more. It's because it's also modulating the sympathetic and the parasympathetic at the same time. It's that same. Ultimately, it's almost like still this 2 against 1 thing, where you're still getting more parasympathetic than sympathetic. Well, just let me confirm that, but that's what it seems like when you combine these things together. You see that you're in favor of calming things down at the end of the day. It's just that maybe one thing happens faster than the other. So I did see, that the blood pressure could go up transiently, but then go back down. Okay, and that's something to be aware of, but it seems to have this balancing act. That's the thing, because it's hitting this other receptor more powerfully. Nicotine is more of a stimulant, and cytisine is more of the balancing act, and those receptor combined, but it's at the right balance that it seems to be destructive towards cancer. It seems to help cardiac dysrhythmias, according to one article, but it's not driving the blood pressure up. It's actually maintaining the blood pressure. It's not dropping the blood pressure either. Okay, so it seems to be that nice balancing act when it's used appropriate, when it's done right.
Are you treating lots of Parkinson's, or just some, or how's that going?
Yeah, I'm getting more and more complicated, very complicated cases that I'm becoming more comfortable in treating. So I've had my journey through Parkinson's, starting with selegiline, actually, and getting a response with a patient who actually saw one of the biggest gurus out there, very popular, and got put on I liked the supplemental regimen. It's just his hand was still tremoring, and he's only 60 years old, and I put him on selegiline, and the tremor was remeasured at a clinic, and was significantly better. Now, when I think about Parkinson's, now I think of, okay, now what else can we do? What other mechanism can we gently affect to improve him even more? And right now we're doing a collecting data on Clotho, a master regulator of well, I would say it's the master regulator of nerve conduction and nerve homeostasis, but it's really the master regulator of calcium homeostasis, or you could say mineral homeostasis, and many other things. And and then, you know, I could see where cytisine would be have a place. However, it comes out, maybe it's the form of Chan stick, but we're at the beginning stage of it. And the reason, you know, I haven't started the cytisine yet is because, you know, it's like, look, you know, I don't want to have to order things, you know, from overseas, or, you know, I'd rather, especially if when you're dealing with Parkinson's and you know that the pill is, it could be better if you can get the route of administration better, because we have to get it to the brain. If only 30% is getting to the brain, I don't want the patient to take it and say, yeah, I'm not so sure if it's making a difference with, even though physiologically it's probably doing something. I would rather see, I like results. So I'm waiting for the nasal spray. I hope that answers your question. So yeah, I treat give me any complicated case and I will go to town on it and try to figure it out. And,
is it water soluble? Cytisine is a water soluble?
Yeah, well, I think the idea is that I actually have, I just, you know, received it. Where I have a pharmacist that's comfortable with it, with its purity. We're going to see, we're going to make it fat soluble. She said this pharmacist said that they can make it fat soluble at the appropriate dose, and then we'll, you know, I'll give it a try, and see if there's a difference.
You mean you got the pure powder?
Yeah.
Okay.
Okay.
Oh, I hope I don't get in trouble for that. I mean,
No, we're
you know.
we're good. We're good.
Okay.
We're good.
Thanks for your time. I hope this wasn't
you.
too long. I know it's getting late.
So
I don't. Go ahead.
Dr. James, how dare you practice medicine like a physician's supposed to?
I know.
That's not it. That's not according to the rules.
I know. It's like
you're gonna be on double secret probation before you know it.
Yeah. Heaven forbid it actually works and you help them.
I know. I feel like it's a crime just to, you know, but you know, like I said, it's we try to keep it, you know, we keep things, you know, private, behind, you know, put it out there and, you know, put it on big billboards, you know, and I understand it's, you know, we're taking chances on ourselves, you know, to a degree. You know, we understand mechanisms, but you never know.
We need to protect Dr. Joseph from the big pharma now, because, you know,